Hi, everyone. Welcome to the Global Nexus Conversations. The topic for today's virtual roundtable is intersections of race and healthcare, lessons learned from a pandemic. I'm Chandrima Chakraborty. I am a professor in the Department of English and Cultural Studies, and I am a research lead for Global Nexus at McMaster. And I'm joining you today from Hamilton, where McMaster University is located. And I want to begin by acknowledging that McMaster University is located on the traditional territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. The dish with one spoon implies that we all eat out of the dish. That is, all of us share this territory, this land, with only one spoon. We are asked to share the responsibility of ensuring then that the dish is never empty, which requires taking care of the land and those we share it with. Each of us have been invited into this treaty in the spirit of peace, friendship, and respectful coexistence. We acknowledge our debt to those who were here before us and recognize our responsibility as guests to respect and honor the intimate relationship Indigenous peoples have to this land. As we gather here today for our Global Nexus conversations on the intersections of race and healthcare, the ongoing pandemic reminds us more than ever, I think, how each of our well-being is tied to that of others. We are reminded of our interdependence on each other so that each of us can be well, so that we can live well together. But we also know that the pandemic has made starkly visible the existing inequities in our society. And today we have with us a wonderful group of panelists who will offer us insights on the root issues that contribute to poor healthcare experiences in racialized communities, and the work being done by academics, by healthcare leaders, and community leaders. So we will be talking about what lessons we can take from COVID to inform future healthcare practice. We have three panelists with us today, and each member of the panel will take about 5 minutes to frame their remarks around the question, has the pandemic simply highlighted existing inequities or also created them? And as you're listening to the panelists, audience members are encouraged to post their questions using the Q&A feature at the bottom of your screen. You can direct your question to a specific panelist, or you can ask all panelists to weigh in. Now to introduce our three panelists. Dr. Fatimah Jackson-Best is an assistant professor in the Department of Health Research Methods, Evidence, and Impact at McMaster University. She's also a project manager at Black Health Alliance for the Pathways to Care project, which seeks to improve access to mental health and addiction services for Black children, youth, and their families in Ontario. Her work focuses on mental health amongst Black communities and in Canada and the Caribbean. Welcome, Dr. Jackson-Best. Our next panelist is Kenneth Fung. Dr. Kenneth Fung is staff psychiatrist and clinical director of the Asian Initiative in Mental Health program at the Toronto Western Hospital University Health Network. He's professor and director of global mental health with the Department of Psychiatry, University of Toronto. His research, teaching, and clinical interests include both cultural psychiatry and psychotherapy, especially acceptance and commitment therapy, CBT, and mindfulness, with projects and collaborations in China, Hong Kong, and South Korea. So we will begin with our first question. We are still waiting for our other panelist, and when she arrives, I will introduce her. So we will begin with Dr. Jackson-Best. Has the pandemic merely highlighted existing inequities, or do you think it has created them?
Thank you so much, Chandrima, and thank you so much for the opportunity to participate in this Global Nexus discussion. I think this is a really good question that I get quite a bit, and I have thought about a lot because of the pandemic. I absolutely think it's not a either or situation. It's absolutely a both and response that I'd like to give you. The pandemic absolutely highlighted existing inequities, particularly for people who are from communities that have been made marginalized, which include Indigenous, Black, people of color, LGBTQ communities. And it also created new inequities with regard to lack of access or differential access to technologies such as the COVID-19 vaccine. So my research and my work is mostly focused on Black communities and Black communities both here in Canada, but also in the Caribbean. And there were a lot of similarities that I noticed in Canada and the Caribbean, but I'll localize my response really to a Canadian context, since I assume that's where most of us are from or living. So in the Black community, there were already existing inequities when it came to issues such as mental health care services. And so what the pandemic really did was that we know that new mental health challenges and issues, increased stress, exacerbated stress, anxieties, and exacerbating existing mental illnesses were, for lack of a better term, increased during the pandemic. And there were some new ones also cropped up. We see it amongst Black youth and people who, previously didn't have mental health challenges. So the issue that also was underlying or was already pre-existing for many Black communities was that we have a very inequitable access to mental health care services. So that was already existing before the pandemic. I've been working on the Pathways to Care project with Black Health Alliance since 2018. And one of the biggest statistics that jumped out at us when we were doing a systematic review was that Black youth were waiting at least 16 months to receive mental health care service supports or access to services in cities like Toronto, Montreal, et cetera. And in comparison to white youth, who typically wait about 8 months, both wait times are absolutely, untenable and unhelpful. But the fact that Black youth are waiting twice as long can create exacerbated mental health care symptoms and can lead to Black youth being coming through negative pathways into care through the police, the justice system, and hospitalization. And so with that kind of context already existing, this inequitable access to mental health care supports, something like the pandemic layered atop of it just makes things worse when a lot of mental health care services were closed or they were only accepting online services. Not everybody has access to online services. So that's one example that I wanted to use to really illustrate the inequities with regard to mental health that were already existing. And then, as a result, new inequities crop up. So as I said, the lack of access to COVID-19 vaccines, where Black communities and Southeast Asian communities were contracting and dying from COVID-19 in provinces like Ontario and all over North America, if we're completely honest, contracting and dying from the virus at higher rates. But when it came to vaccination rollout, those same communities that were COVID hotspots were not given increased access to COVID-19 vaccines or testing. So, it's always for me going to be a matter of both and. I think that we need to, really reframe the way that we think of things as being new. A lot of these things are continuations from already existing systems that we are made to live in.
Thank you. I know, Dr. Fung, you've done quite a bit of work in terms of Asian communities. So from Dr. Jackson Best, we got a sense of, Black communities already undergoing a lot of inequities and mental health illnesses, exacerbated services not available. What is your sense, or if you could share your perspective based on your research on Asian communities? Thank you.
Thank you. Thank you for inviting me. And I think this is such an important topic and question. And just want to say I agree with 100% what Dr. Jackson Best had just articulated so eloquently. I think that we all know that disparities and inequities exist for marginalized communities pre-pandemic. And that is, the disparities can be seen in various social determinants of health, including income and housing, and also health. And in particularly mental health, for example, in Ontario, there's a study that came out before that looked at the Ontario psychiatric hospitalizations and those who are hospitalized, in particular Asians, including both South Asians and Chinese in particular. They are even more sick and more psychotic than the average patient. And another studies showed that Chinese population had very low rates of diagnosed depression, and yet they rate their mental health the poorest. As well, they have the lowest sense of belonging as a part of the community. So we see these figures reflecting, and somewhat perhaps surprising to many, oh, Chinese people they don't expect them to have such a high utilization. I think that's one issue, which is the fact that it should surprise people that when we really look at data, that there are disparities for marginalized. When COVID hits, we know that from a global perspective, even the availability of vaccines, many countries had it much later due to various issues. So we know that there's inequity even in vaccine availability in a global scale, but also in North America, where, as Dr. Jackson Bess pointed out, those who are most needed are often vaccines are either made not available, or their own particular cultural issues or diversity issues are not taken into account, where these are groups that have, for many years, have either access issues or trust in the system, and they were not considered in the vaccine dissemination. And we know that there are more effective ways once we take that into account for many minoritized communities, if we take into account. Talking about racism, I think anti-Asian racism, for one, has become an emerging topic. I've been in Asian mental health for like 20 plus years. I've never once been asked to give a talk on anti-Asian racism until the pandemic hits. So when you talk about the pandemic highlights certain issues, I think this is one issue. And whenever I talk about it, sometimes I surprise even when I look at it, is that it actually started from the founding of Canada with the railroad. So it's a very historical issue that then has evolved into the Chinese head tax, then the Chinese Exclusion Act, one of the only ethno-specific targeting one single race in the immigration policy of Canada in its history, until 1947, when Canada wanted to join the United Nations to sign on the Charter of Human Rights and found out that you need to drop it in order for Canada to sign on. That's when Canada finally dropped the Chinese Exclusion Act. So it's not as if racism didn't exist. But one of the reasons that is not talked about and the disparities are not talked about is also what we call the myth of model minority. That, oh, Asians in general, like the Chinese, Koreans, or East Asians or South Asians, they don't have much need because they work hard. So it crafts a false narrative. First of all, if you look at it, yes, there are successful people, but there are also lots of people who are marginalized. But by saying, oh, they work hard, they would overcome barriers, it actually pits one minority group against another. It starts to blame other groups for not working hard enough. And it also perpetuates the myth of meritocracy. Those who got it less, those who are in the jail system, well, they just don't work hard enough. So it actually does a disservice to all minoritized groups. And it really sweeps under the rug all these disparities when we actually look at it. So all groups, any inequities across all races needs to be addressed, and we need to all work together to do that. And for anti-Asian racism in particular, last year is the first National Forum on Anti-Asian Racism hosted by UBC. And there's a document that comes out with some of the key takeaways and recommendations for different sectors. I think that's one thing, which is racism penetrates across all sectors, from housing to health to legal, which is a huge issue. So we need to look at this kind of broadly across sectors. And then in health in particular, there are many kind of recommendations that come out of it, including implications of the kind of research that we need to do that Dr. Jackson Best had referred to and that I have alluded to a little bit, to representations at all different levels of health that needs to be there. Disaggregated data needs to be there. There needs to be cultural safety, cultural competence, EDI, training on structural competence. All those things need to be first and foremost as we reform the healthcare system, and communities, different minoritized communities need to be empowered to champion for their issues. I think all of those need to be part of the solution as we work together towards a better health and better equity in the system for everyone.
Thank you so much, Dr. Fung. Like, you've brought up, number of issues about, trust in the system, about, sort of the diagnosis numbers not really matching what patients are reporting in terms of mental health issues, questions around the model minority that takes away attention from the structure. So we don't have to talk about the structural discriminations or inequities, and we focus attention on the people who can pull themselves up, issues. So I would like now to bring in Lacey VanEvery into our conversation, and I will just first introduce Lacey VanEvery, who can offer us, another perspective, I guess, from the Indigenous perspective. So we've heard, the effects and the impact on Black communities, Asian communities, and now we can, have another voice come into play here. So Lacey VanEvery is a committed healthcare professional who works hard to see positive health outcomes for Indigenous people and keep her community safe. A member of the Cayuga Nation Turtle Clan, she's Haudenosaunee, from 6 nations of the Grand River Territory. Lacey is an assistant nurse manager working with Indigenous Services Canada, First Nations and Inuit Health Branch, Ontario region. Prior to this, she was the nurse in charge of Genio's Community Health Center, including Oshwekan Public Health. That role in particular put her on the front lines of the battle against COVID-19 and the public face of public health through community updates, interviews, and podcasts. Lacey has served on a number of committees, task forces, and initiatives to advance research and health of Indigenous peoples, and she's an active mentor for Indigenous students and youth. Welcome, Lacey VanEvery. And if you could offer your thoughts on whether you think the pandemic merely highlighted existing inequities that existed prior to the pandemic, or do you think that new kinds of equities came into existence as a result of the pandemic? Welcome and thank you.
Scano, everyone. Thank you for having me today, and apologize for being late. Yeah, I just had some technical issues on my side. So I hope you can hear me okay, because my internet has not been the greatest lately, but I did make some notes. So I'm just going to kind of go through some of those notes that I made. The question you pose, it's an interesting question because it highlights that inequities do exist. And I think for that, it's a term that we've been grappling with in regards to Indigenous health and Indigenous healthcare access. From my experience of being an Indigenous person and called to respond to the pandemic for my community, I went in knowing inequities exist. Therefore, any decision and recommendation came from a place that the existing healthcare system will not prioritize people of my population. We've seen it, we heard it. We can make excuses that healthcare providers were exhausted and whatnot, but it's embedded in the historical aspects that Dr. Fung has highlighted, and Dr. Jackson Best as well, that, it's in the legislation, Indigenous health and the healthcare access. It's always been a limited function for our populations here. So what had happened was we seen, the approach to Indigenous people. There's still discrimination, a discriminatory lens that has been applied. That's not really helping a lot when community members are seeking care, especially in a situation of a pandemic. I knew this, and I believe the rest of the response team knew this, which is why we were extra cautious in the approach as we applied to all of our community. One example I can speak to that really came to light during this experience was an individual who had tested positive for COVID and was having difficulty breathing. As a nurse, we looked at the assessment pieces of that from the telephone assessments that we were able to conduct. The symptoms, they were in line with either an underlying issue, an infection, any other cause. And we knew that there needed to be further investigation into the symptoms. So directing that client to hospital, knowing that at the time these individuals would need to be going in alone, we've developed over time, I guess, to kind of backtrack that, support people for Indigenous population seeking healthcare. They're really important because they assist that individual in addressing any concerns that they may have. Oftentimes when you're unwell, you don't say all of the symptoms that you have, but having a family member present really helps them to tell their story. But at the time of COVID, that wasn't possible because individuals had to go in alone. They couldn't necessarily have that support person with them, which caused, a lot of anxiety for people going into hospitals. A lot of people have a notion you go to a hospital to die. That's just been an ongoing issue with our people as well. And it was exacerbated through pandemic. They couldn't breathe. That's a scary thing, and to go in to seek help. We had one individual who went in and they were asked, hold on a second. Yeah, so they went in and, we thought chest x-ray, get an understanding of what the underlying issue was. Instead of that, this person was approached by a physician and asked, what do you want us to do with your body? Who asked that during an opportunity of healthcare engagement? That in itself was an example that this person carries with them, and any further engagement with the healthcare system will take them back to that experience. And our people, they do talk. They talk amongst each other. They share their experiences within institutions outside of our community. And this is something that other individuals will carry with them as well, because they're thinking the same thing. Is this how I'm going to be approached when I'm seeking help as well? So to see that type of inequity exists, like, did that doctor approach other patients like that? I can't speak to that, but it really highlights that, how our people were approached, knowing that this person was alone, didn't really have a good support person with them to help support them through their illness. It really asks a lot of questions of our systems. I know there's change. That's happening, that's coming to addressing and creating more cultural competence in our healthcare practitioners, but it's still incremental how it's happening, and it's not really addressing the access. We look at the response from a community perspective. In a lot of First Nations communities, a lot of communities went into shutdown because they wanted to protect their community members. They wanted to limit the access of any outside illness coming in. This takes us back historically to colonization processes where a lot of illness was brought in from outsiders. So we're still dealing with that historical trauma that has occurred through our generations. And these experiences really highlight that we don't have access in communities. We don't have First Nations communities that hold hospitals. We had to seek getting groceries outside of our community. A lot of communities don't even have a grocery store. Food security, our social determinants of health that really impact equities. It not to simply highlight that they exist, but to understand that pandemic did exacerbate a lot of that. For communities that were in lockdown to go into town to get groceries and be discriminated against because their community was in lockdown, like that, those types of experiences were happening. So and then looking at the overall legislation of Indigenous health, it's not really clear who takes the responsibility of First Nations peoples in their healthcare, and then looking at our approach to it. When we looked at the provincial guidance that came out, it was specific to our province, our region. And a lot of times in First Nations communities, it was also taken. But it wasn't, to me, it wasn't created with my minority populations in mind. There was a lot of gaps in that guidance in promoting protection of individuals. I think there was some assumptions that anyone who needed access to services could get it. That's not always true, especially in First Nations and Indigenous communities. So yeah, I think that's good. Thank you.
Thank you so much. So all of you, brought up issues of trust, given the long-standing discriminations and inequities that are both written into policy, as Kenneth talked about it, and then Lacey, you offering us, some of these, examples of people going to seek healthcare and the kinds of responses that they're receiving. So it seems like that we need different kinds of partnerships. So then my question to all of you is, what do you think would be partnerships that are now needed between communities, health system workers, policymakers, given that we now have the experience of this pandemic? What could we do differently to avoid the same issues in future pandemics? So yeah, if any of you could start, and then we can, get responses from all of you.
I'd be happy to start. I think that what this, for me, in terms of working in Black communities and also being connected to Black communities, my family, Black Muslim communities as well, it really spoke to, of course, this lack of trust and the issues that Black communities, like so many communities, have with trusting our governments, trusting that our elected officials, and trusting that those elected officials will be beholden and responsible to our communities. And also the lack of trust. I think what really, really was pronounced during the pandemic was the lack of trust in the healthcare system. When so often when even though I mentioned that there was an inequitable rollout to COVID-19 testing and COVID-19 vaccines, there were also people, of course, in our community and in various communities that stated that they didn't trust the government, they didn't trust healthcare systems, and this is rooted in historical context. There's so many examples that Black people can refer to where healthcare systems have ignored them, have led to disablement, death, etc. So many people were also in Black communities were also referencing Indigenous communities and the Indigenous woman in Quebec who died in a hospital even though she was asking for help, right? So a lot of Black people have this deep mistrust of the system because they see so many other people who have been who have been the recipients or have died basically because of the healthcare system. So and we don't trust that our policymakers are also going to work in our best interest. So what I think we really need in terms of partnerships are ones that restore trust, and maybe restore is not even the right word because there's a lack of it already, but ones that foster and grow and nurture trust between, healthcare systems, policymakers, governments, and Black communities and communities that have been made marginal. It starts at that very basic level of, creating relationships and, not that don't feel tokenistic or don't feel opportunistic, right? A lot of the times, Black communities, we say, policymakers and politicians will come into our communities for elections and make promises, and then we'll never see them again, right? And that contributes to the mistrust. So at the very, nucleus, we need to see very strong, strident, and real commitment to fostering and generating trust. And then we can think about how we can create partnerships with hospitals, with government, with policymakers, so that we can ensure that future pandemics are not as severe and don't have as severe outcomes as the COVID-19 pandemic. But it's going to take consistent and regular and standardized kind of engagement with our communities because even myself, I work in this field and I have a level of mistrust. And I tell people that all the time, just because I'm, a professor, I'm a researcher, et cetera, doesn't mean that I automatically take things at face value. I have to also, I'm couched in my own cultural and racial context. So, people need to understand that, and then they need to meet Black communities and communities that have been made marginal where they're at.
Kenneth, yeah, please.
Sure. I'm not sure if we're going in order, but yeah, I totally agree with what Dr. Jackson Best had spoken about. I think that in this pandemic, first of all, even those in the science and health community might look at policies, and we see that there's obviously a lot of politics around it. There's no doubt about it. And a lot of the measures are kind of head-scratching ones, like, a certain size of gatherings is okay, but not, or changing the time of the closing of the bar. Some of it seems pretty arbitrary, or when measures seem to be dictated also by other interests, like business interests and things. So the fact that oftentimes the politics of it, it's very transparently over-trumping science, I think undermines trust in the community. And I think that mistrust certainly extend to vaccine. I know that's kind of in the question Q&A as well. That I know that some of the global health researchers are telling me that this is very obvious in many countries where there's a mistrust in the healthcare system, that suddenly there's a vaccine, then there's even more misgivings about it. And then local research, and I think a lot from the Black community research has really demonstrated that trust is a huge issue about vaccines uptake. And one of the trust building, it's about also racialized representation at all levels of government, at all levels of healthcare that can foster trust. I think that's an important piece. There are various kinds of ceilings. In Asians, we call it the bamboo ceiling, that Asians are seen as good workers, but not if you let them get to the top, or they're not good at politics. So there are certain stereotypes that kind of go along with that too. I think that a lot of policies are, just like the rest of healthcare, ignores the cultural needs, the linguistic needs, and the diverse, the needs of the diverse populations. I think as Lacey had, Dr. VanEvery had talked about, that when there's vaccines and there's also lockdowns that don't take into account people's realities, that may work for certain segments. Oh, just do virtual things, but many jobs, especially minoritized jobs, don't lend themselves to just do it virtually. And when you have lockdowns, when you send children home, it's not the same for every kind of family. It doesn't work for all communities. Homeschooling doesn't work for all communities. These are examples of policies enacted in emergency that pays little consideration to what it means to diverse communities, and also to do, if we talk about intersectionalities, that opens up even more questions. And I also work with the disabled community, both mental health, but also intellectual and autism. For those communities, lockdown means a huge deal. When you have children with special needs, suddenly they're home, and parents who cannot just work from home, it becomes disaster. So those needs are never part of the equation. Of course, we see those who are most vulnerable, including women, including those with disabilities, those in the geriatric population, those in nursing homes, especially racialized nursing homes that we've been called to help out on. They are just pummeled by the pandemic, and it really shows. And during the pandemic, because there's such a more huge overt rise in racism against the anti-Asian crowd, there is a lack of preparation of how to deal with this huge rise in racism that's documented in 1 year. Thousands of cases of racism have been documented voluntarily on a web portal, which most Chinese people don't even know about. So many of my patients have no idea what to do when they were spat on, they were pushed, they were shoved. And there are a lot of incidents. Many geriatric Asians are afraid to go out because they were pushed and violently assaulted in some cases, and spat on in the pandemic, and told as causes of the virus and call names. They were emboldened by the politics of the environment coming both from the South and etc. So I think that all these factors, we have to look at how do we address it together. And I think that the best way to address it is to really work with all the communities. A community-based approach really needs to be taken. Communities need to be empowered. They need to be around the table as opposed to from really a top-down centralized approach where there's a lot of ignorance about the diverse needs. So we all need to be part of the solution instead of seeing, part of the, problems. I think that needs to be a basic shift in attitude and how health policies are made. Thanks.
Lacey, did you want to weigh in?
Hi. Yep. So just looking at, the whole issue about trust and our approach to the pandemic. I think some of the points that stuck out to me was we need time. Everything was very rushed. Nobody wanted to make the wrong mistake. And I think that put a lot of pressure on decision makers globally, I think, in how to approach the pandemic. What I found from my experience is you need time for engagement with your leadership, engagement with your community members to get messaging out there, that rapport that you have to create, in order to make sure that the right information is getting out to the right people. One of the, I guess with the vaccine rollout that we've seen in our community, one of the most challenging things that I came across was having to prioritize a priority population. How do you get a limited supply of vaccine? How do you prioritize your population in that? And, we sat around as a group and really tried to tease out, how we're going to make this happen. And that was a lot of pressure and a lot of stress, on making that happen. And then we looked at the ongoing vaccine rollout, and we identified that we had a lot of people who are not community members coming to our community to get vaccinated, because at the time everybody wanted to get it done. That's great. You had that eager population that was willing to get vaccinated in order to kind of avert some of the adverse effects of COVID. It would make sense. They want to protect themselves, they want to protect their families as best as they can. But in the long run, we're still seeing, that lack of engagement of vaccinations. There were policies that were put in place almost to enforce vaccinations on some individuals. Like you couldn't travel unless you were fully vaccinated. And for our people, we have family not only here, but on the other side of the border. So it made it really challenging for families to get together during that time if they didn't feel that vaccination was the right choice for them. So we didn't consider that in the decision making. It was just an automatic policy that, you had to be vaccinated in order to cross the border. So when we look at, I guess, longer term planning, it does need to happen. Like you need to have, I think at this point, engagement to have plans that had been enacted, documented, because along the way it's hard to document these decisions that had occurred in order to respond to the X number of waves. I don't even know what wave we're on right now. The number of waves that we had to deal with COVID. So I think creating that toolkit and just making it more available, will help communities to be better prepared for anything that does come up again. The other point I noted too during our response was the relationship we had to have with our public health units. For First Nations on reserve communities, that's not always the best relationship, even though public health units are to help to oversee First Nations communities. That in some communities was strengthened, that collaboration between their community and a public health unit, and we are seeing that happen now. With the vaccine rollout, there was some the data sharing hasn't been the best. When you deal with public health units, they deal based on the provincial markers to identify individuals in that system, and it was often postal codes that were used and weren't necessarily tied to the communities. I know for my community, we have like 4 or 5 different postal codes that the health unit would have to be knowledgeable about in order to pull some of that data out for the community to provide a report on vaccination coverage rates, you know. So hindsight in a lot of First Nations communities was documenting at the time, you know, they relied on the health units to provide those reports back to them, and at this time we're still finding that a challenge to get back in some communities. The other thing is engagement, you know, engaging with community members and making sure not just on reserve, but urban Indigenous community members are engaged with. We had some urban centers that were reaching out to us in our community for ideas on how to reach their urban Indigenous populations, because that was a gap that was identified as well in terms of access to services. And we did see a lot of urban Indigenous individuals coming to our vaccine clinics, coming to seek testing, you know, and to have to put a barrier on that, you know, to identify you have to be a community member like that, that just does not work for our people, because we move around a lot. You know, we have a number of people who are living here in the southern region, you know, coming from a northern region, and you know, we have to accept that we're migratory like that. So yeah, so I think that answered your question.
Yeah, all of you brought up, you know, lots of issues, you know, long histories, memories of discrimination, racism, failures of the healthcare system, and then experiences during the pandemic. And then I see some, you know, questions in the Q&A, and maybe I'll, you know, ask Fatimah to respond to it first. You know, did the mistrust in the healthcare system extend to mistrust in vaccinations? So that's one of the questions that our audience member.
Absolutely. It's a good question. And the short answer is it absolutely did. You know, there were so many people who referred back to a very infamous example of healthcare research, the Tuskegee syphilis trials, in relationship to the COVID-19 vaccine, right? People weren't, they had an inherent and historical mistrust in the medical system, even though the Tuskegee syphilis trials was, you know, done in the United States with African Americans. You heard Black people all over, you know, in Canada, the US, the Caribbean, referencing this as an example of how healthcare basically has essentially been violent to Black people and has led to death, disease, you know, disability, etc. So, you know, the COVID-19 vaccine, I had members of my community, members of my own family, who were very skeptical of the idea of it being developed, as they said, so quickly. You know, the lack of, they felt transparency about, you know, vaccination trials, and, you know, just very relevant, I think, and you know, it was warranted. These were warranted concerns, right? I read a beautiful book recently by a woman named Dr. Nicole Charles. She's a professor at the University of Toronto, and she wrote a book called Suspicion. It's focused on HPV vaccine in Barbados, actually. But it really captures a lot of the same sentiment that I was hearing during the pandemic. People were, you know, relating their distrust of the Gardasil vaccine to, colonialism, to enslavement, to the ways that Black people and Black bodies have been tested upon without their knowledge. People were worried that this was a big test trial or a vaccine trial, like a pharmaceutical trial, and that they were guinea pigs, right? So, as a public health researcher, it was really imperative for me to, wherever possible, to dispel any misinformation first and foremost, and to also talk about the brass tacks, right? So, I had to let people know how important it was for us to recognize that our communities were contracting and dying from COVID at alarming rates, right? And that we were also being, for Black communities, it's not usually about, at least in more contemporary times, it's a lot of the times, and also in terms of the Tuskegee syphilis trials, it wasn't about being tested upon, it was about being refused access to a solution, to an antidote, right? And so in this case, with the vaccine, it was something that I had to indicate to people, this is not an issue of us. The thing that we should be mostly concerned about is that our communities are not getting the equitable access to it, right? And we make decisions from that point, but we need to know that we have equitable access to it. So, long answer to a very short question, but it absolutely did extend to mistrust in the COVID-19 vaccine. And with that, I'm so sorry. It's 12:45. I actually have to get on a flight that I'm watching right now. It seems to be loading up, but I really appreciate the opportunity to be on this panel and to answer these questions, and just all the best for the rest of the event.
Thank you, Fatimah. We don't want that flight to go away without you. So please go ahead, and thank you for your participation.
Thank you so much. Thanks, everyone.
Lacey,
Have a safe flight.
Lacey, if I could pose the same question to you, given you seeing things happening on the ground, did the mistrust in the healthcare system extend to mistrust in vaccinations? Because in your opening comments, you talked about diseases being brought in by colonialism, and that anxiety or worries, or how those historical legacies are getting triggered with COVID-19 vaccination. So did you want to sort of respond to that question?
Absolutely I did. Those historical aspects, we talk about historical experiences as being like long time ago. No, we're like 1 to 2 generations out from it, so it's still very fresh in a lot of our minds when we look at the experiments that occurred at the residential schools, and how that had led to a lot of establishment of vaccines in the country. So I think when we look at this vaccine, it was produced very quickly, and there was a lot of skepticism about it, especially being a new technology as well, and looking at the long-term effects, where there's still some hesitation from individuals to seek vaccination because there isn't enough studies for them to feel confident enough to receive the vaccine, and we did a lot of health teaching with our community. We tried to answer any direct questions that came into our office with the information that we knew. So I think having somebody to actually talk them through some of their hesitations helped in individuals to get vaccinated. It was the overall goal of trying to protect our entire community, making sure we're offering protection for our households, starting individually and then looking at our households as being impacted by those who are unvaccinated. Do you have high risk individuals in your households? Making sure that individuals understood what the impacts of getting vaccinated were. We don't have the answer to long-term effects because it's still very, very new. So, there had to be a lot of trust created within our own community on information sharing. We're sharing information that we received, and making sure that there is evidence behind some of the claims that have been provided, and then looking at the age of the internet, and the information that's out there is overwhelming, and people, and I always say this, people will find exactly what they're looking for. So if they are looking for those negative effects, there are going to be a lot of opinions out there about it. So, those types of technologies we had to kind of work through. But yes, for sure, it did create a lot of mistrust in our community.
Thank you. Kenneth, there are two other questions, and I think it came up based on your comments. And the question is that, how do you suggest that we take a community-based approach? And what would be the difference between a centralized approach and a community-based approach?
Yeah, I think that what I meant is that we need to take a community-based, population-based approach that also has the larger EDI lens approach than a very typical top-down or centralized approach. And I think that we can look at it at several respects. And I think number one would be a representation and the kind of the inclusion at every level of healthcare, and also in politics, in the government. So especially in a pandemic where sometimes it is true that we need like a strong kind of centralized, very quick decision-making process. But this is where if we see those who are in the higher echelons of the leadership, who are the communities who are represented there around the leadership table among politicians. Because yes, in emergency, we need to listen to the top people rather than engaging in months of debate. But who are those top people in the first place? And do we have a representation from a lot of different communities, or is it one single vision, one single voice, and one single perspective? So I think that this means that when it's a non-pandemic time, when it comes to elections, when it comes to civic engagement politics, we need to ensure that there's a diversity of voices around the sitting table so that when there's an emergency, and you're looking at those core, 50, 100 people, experts who are called in. Who are these people who are being called in to finally make it like that quick turnaround decision? So there's that level, and then there is then the research and the science. And we know that typically in research and science, community-based approach is like an approach that is underappreciated, that we need more funding towards. And what we mean by community-based participatory approach often means that it is not like an expert researcher coming from outside to community, get the data, and go out without really a contextualized understanding, nor even engaging in the communities as equal partners, let's say as the research team, so that they can think through issues together. Even the person who's recruiting are from the community. And then when we have results, we reflect it and engage with the community. And then there's something that benefits the community. Otherwise, it breeds all this mistrust we've been talking about, that historically, even when there are community-based or communities that are researched, they are researched on, as opposed to being engaged with as a partners in community-based research. And then once we have all that research and data, how do we disseminate it? And especially in a pandemic, how do we disseminate messages? So we talk about public health promotion, information, education. But then how are we delivering those messages? If there is an information hotline, what languages do you serve? What happens if you don't speak the language? What happens to people who pay attention to ethnic media as their source of authoritative information? So it's an example of how a public health strategy, especially in a pandemic, without consideration to the various communities in terms of language and culture, rural versus urban, and all these factors, if they're not considered, then pockets will be missed. And those pockets who are missed in a pandemic serves nobody any good, because they become, as we see in a really global international setting, backgrounds for breeding of mutations and resistance. So you can see from a population health approach, without that kind of lens, doesn't do anybody a service. And then once you have this kind of public health messaging and talking about access, that it will be what is the access to. So then this is the service end of things. When that access to the actual service, as kind of Lacey shared with us, if people are getting care that's not culturally safe, culturally competent, and it's spreads like wildfire in the community. And again, then it becomes people reluctant to go for services. And then we see the disparities in terms of why are not people who are sick staying at home and not presenting to emerge. And I just presented data. When you look at people who do present to emerge because of the lack of cultural safety and cultural competence, they don't get admitted to emerge. And then there's even further data that even though controlling for medical parameters, they don't even get admitted to the ICU as much as the majority race of people. So at each step of the way, these barriers along the way, from social determinants to the messaging, to the access, to actually getting the care, to getting the most appropriate care, to even getting the ICU, each step along the way, there's disparities that builds up. And then you see the differences in health outcomes that we ultimately see that communities take the burden of.
Yeah, so you brought up, a number of issues here about, who's at the table, so that you can offer culturally informed, culturally sensitive, approaches that can then be adopted in terms of, policy. You talked of, research co-design that involves community input, feedback as co-partners rather than as, as recipients of knowledge. And then you talked about dissemination in terms of reaching people where they are. And then Lacey talked about, the role that you had to take on as, a health educator in terms of the community. So, we're reaching the end of our time. So maybe if I could, ask you a final question, and if, have your thoughts on it, like, what do you believe would be the immediate priorities? What do you believe the immediate priorities should be to improve the outcomes for marginalized and racialized groups in, healthcare settings in terms of, your experience and your work? Could you identify for our audience, one or two priorities that are, high up there for you? And we could start with Lacey and then maybe Kenneth.
All right. Can you just repeat that question?
Yeah, given all of this, historical legacies, trust, issues of, healthcare delivery, what would you identify as an immediate priority that could be adopted so that we can improve the outcomes for the communities that, you are working with, communities that you are researching? If you could identify one or two, high stake items for us so that we can, move this conversation forward, or we perhaps, the lessons that we have learned so that we don't repeat the same mistakes over and over again.
Okay. I think the most prominent priority is especially for specifically healthcare providers, healthcare professionals, which could also lead to policymakers, is really to step back and identify their own biases when it comes to engaging with minority populations, discriminated against populations, and identify their role in it. A lot of these issues that I brought up are essentially systemic issues that have been ongoing for quite some time now, and it is embedded in some of our legislation when it comes to Indigenous peoples, Indigenous populations. So when we look at how we can make some immediate changes, it does come down to the individual, and really identifying their role in the system and how they can make improvements to better see people as people, not seeing color, not seeing race, not seeing social circumstances, just seeing people as people. And when you have people that come to you for assistance in the healthcare institution, you can better identify those precise needs that they have when they do come to you for help, and not necessarily making assumptions as to what their background is, what situation they're coming from. So that, I think, would be an immediate priority to kind of assist with this. When we look at, well, even from the community-based approach, what I'm seeing now is a move, a shift, I think, in some of the thinking when it comes to First Nations communities. So there's a lot of talk about self-determination and making that a reality for a lot of First Nations and Indigenous populations. how did we get to that point? We had this national report that went out on Truth and Reconciliation, the national report on missing and murdered Indigenous women. There's a lot of calls to action in there, and steps that people can take to make everyday changes to how they approach other people. I think it's also recognizing that we all have a story. And I know like healthcare providers don't go in with the intention of, I'm going to make somebody's day crap today. I'm gonna, that's my goal. Nobody has that intention, but I think it's identifying where you're in that space as well. If you need help, I think healthcare providers reaching out and seeking help for themselves as well is probably going to help a lot of this, because I think a lot of this could be stress induced that they're presenting this way to a lot of individuals, and it does come from that systemic issue. So I'll leave it at that.
Thank you so much. Kenneth, you get the final word here.
Yeah, I think that I agree 100% with what Lacey is saying. I think that the priority comes back to the EDI, or Equity, Diversity, Inclusion Principles. I think that everyone who's listening, you all have your own sphere of influence, because we just talked about the system. Everyone has their own power and influence, and all of us has a part to play in this. I know that when we talk about these disparities, there are many kinds of different reactions. Sometimes there's guilt, sometimes there's anger, sometimes they're saying, why blame me? I didn't do anything wrong. The historical legacy is not on me because I'm young, or reactions like that. We're not here to blame anybody, but we all have a role to play as part of a system. So that instead of a kind of a us versus them mentality, I think it's crucial that all of us work together. I know that initially the pandemic is presented as we are all in this together, we're going through the same storm. And then I know that there's a lot of talk that, oh, we're in the same storm, but we're all in different boats. And I think that is to recognize that we all have disparities. Although I would like to take it one step further and say, no, actually, we are all in the same big boat of humanity. It's true that some people are historically marginalized to the lower decks of a ship, and some are like in the higher decks of the ship that has so much more privilege. But at the end of the day, we sink as all of humanity. If we don't recognize that this is all of us, each one of us is important, and that taking care of someone who looks completely different from you is the same as taking care of your own grandmother. If we can have that mentality, that what Lacey's saying, you're not seeing, oh, this is of a different color, this is like not me, this is someone else who will fix the issue. If we go beyond that and have this idea, and a lot of the Indigenous teachings would help us even in this area, that we are all connected, including in the environment. And I think by pulling together, we can all build a better, a safer, and more equitable tomorrow together.
Thank you. This was lovely. This was a lovely way to, conclude, reminding us of our responsibility, our humanity. Thank you so much for joining us today. Thank you to our panelists, and thank you to the audience. And we look forward to seeing many of you at the next Nexus conversations. Have a good rest of the day, everyone. And thank you to the panelists. Thank you so much. It was a very enriching conversation. Thank you for joining us.
Thank you so much.
Thank you.